Yes, sir. I'm a fourth-year medical student, Fernando Moreno-garcia from the University of Oklahoma. And today I'm going to be talking about the Millon Behavioral Medicine Diagnostic and its potential to predict bariatric surgery program preoperative dropout versus reaching bariatric surgery. Neither I or any of the authors in this study have any disclosures. So what you're looking at here is a representation of about 2.67 times the population of the United States. About 890 million people in the world are living with obesity right now. And obesity has very many well-known comorbidities. And all of these comorbidities, as well as obesity, are treated definitively and effectively by bariatric surgery. And we have seen that this procedure is very underutilized, with only 1% of the population that is eligible undergoing this procedure. And when we look at studies that are looking into people that do not make it to bariatric surgery, it has been reported up to 60.8% of patients do not make it into bariatric surgery. And various factors have been investigated. What the data does show is longer wait times, male sex, smoking, and biopsychosocial pathologies have been associated with bariatric surgery program cessation. And the results between BMI and age and their influence on this is there have been mixed results. And it is this lack of clarity and lack of data that we focused on for this study. The MBMD is a commonly used self-reported measure of 165 questions that assesses potential biopsychosocial factors that may influence a patient's health status and ability to participate effectively in a multidisciplinary treatment plan. It is composed of 38 scales which span 7 distinct domains. And as the symptoms are more problematic, they score higher on these scales. And there are also clinical cutoffs. So a patient can score in the little to none, moderate, high, and severe range. And then the response patterns and negative health habits categories or domains, these are more categorical. And as you can see here, this patient is eating will be a likely problem area for this patient, whereas drug or inactivity would be a possible problem area for this patient. And there is limited data on the predictive value of MBMD for preoperative cessation versus success. And this was the main aim of this study, to see if the MBMD can predict whether or not a patient will or will not make it to surgery. This was a retrospective observational cohort study of adult patients at the University of Oklahoma between December 2017 and December 2023. And after patients enroll in our program, they are seen by a clinical psychologist, and during this evaluation is when they take the MBMD. After this, patients fell into one of two categories: those that made it to surgery and those that did not make it to surgery. We collected clinical and demographic data, and time to surgery was calculated as, or defined as, days from program start date to surgery date, and the baseline BMI was defined as what a patient's BMI was when they started the program. These were the statistical tests that we did. And out of 705 patients, 17% were male, 83% were female, and 30% of our patients did not make it to surgery. Whenever we looked at men versus women in this regard, we found that the male sex was a higher risk of not making it to surgery, and starting the program at a higher BMI, a baseline BMI, was also associated. And the patients that actually went to surgery, we found that the longer their time to surgery was, the less weight they lost at 1 year. And when we look at the MBMD, we found significant differences between the two groups throughout many scales, from attention, anxiety, tension, depression, cognitive dysfunction, emotional ability, and guardedness. And important to note that the depression scale did see a difference in the clinical cutoff, with the attrition patients scoring higher in the moderate range. This was also seen in the coping styles, where we did see various scales that were different between the surgery and nutrition groups, but in the dejected scale, we did see it also crossed the clinical cutoff. And it was interesting to note that our surgery patients did score higher in the problematic compliance. And whenever we look at the response patterns and negative health habits domains, we did find that the patients that made it to surgery were 2.6 times as likely to being scored as having 0 possible problems that would interfere with their treatment. And it was also surprising and unexpected to see that our surgery patients were more likely to have disclosure as a possible problem area. This result may have been due to the patients who did not make it to surgery viewing surgery as a last resort and were more open about their health as they explored more options. And the association of higher pain sensitivity in our cessation patients may be due to an increased association that has been seen in other studies of sedentary behavior that would not be conducive to the necessary changes for success in a bariatric surgery program. And there were a few mixed results between our study and other studies, in that a study by Taylor et al. Did find higher baseline BMI was associated with cessation, DeMorris et al. In the present study, and there was contradictory results by a study done by Gill et al. And this was similar with our findings on gender. The main limitations of the study is that it was a retrospective, and that some of our surgery patients took over a year to make it to surgery, while some of our patients that were included in cessation had not had a year since their start in the program. In conclusion, the MBMD does show some promising results in predicting whether a patient will or will not make it to surgery. And there are significant health disparities between these two populations. And an emphasis on biopsychosocial evaluations and the MBMD can allow us to tailor treatment plans for patients pre-op and post-op. Thank you.